Now, next thing, deficient testosterone. If you're missing testosterone in a male child early on in gestation, the reason it says ambiguity in male genitalia is because if you don't have testosterone, you're not going to make the penis and the scrotum. So of course it'll be ambiguous because it means you don't have a formed penis and scrotum. Now, in the third trimester, you may have an undescended testicle and you will have a penis, it'll just be smaller than you expect. Now, at puberty, the deficiency is in secondary sexual development. That means things like hair, voice, and pubic hair, voice, and penis size. And penis size will stay small. So no matter how you slice it, not enough testosterone makes a small penis. If it's very early, it's so small as to be mixed up with a clitoris. If it's third trimester deficiency, it is a normal shape, just small. And if it's deficient at puberty, it's still small, but not quite as small as it was if it was deficient in the fetal life. In other words, the earlier on the deficiency, the greater the effect on the size of the genitalia. The earlier the deficiency. Deficiency at puberty means you're missing the voice changes, the hair changes, the muscle changes. That's secondary sexual characteristics. Big pectorals, big deltoids, big latissimus dorsi, pubic hair, voice changes. Okay. Next, late in fetal development, the penis and the prostate and the scrotum are there, they're just miniaturized a bit. Early in fetal development, you can have it be so small that the scrotum can look like a labia and the penis can look like a clitoris. Our last slide in the male reproductive section is to look at these tables, which could be a little bit difficult at first until you realize that primary hypogonadism is the same thing as being postmenopausal. You might say, but we're talking about guys here. Not really any different. It's like thyroid failure. Well, instead of sex hormones, what if we were to say T4? And instead of FSH, what if we said TSH? Well, what's the difference? Just think of it like low thyroid. Your thyroid hormone is low, well, your TSH would be up. Now, what's the difference between that and the pituitary failing? Well, the gonadotrophs are down. Now, isolated gonadotroph failure of the pituitary. Again, the pituitary is a very small gland, a couple of grams, barely. So we're talking about the most tiny, tiny amounts of volume. So most people who are going to have a failure of the gonadotrophs will have panhypopituitarism. Now, one of the other types of gonadotropal failures is things like Kalman syndrome, where you have a low FSH and LH, which is a very good question because it actually asks a genetic defect where you're not making FSH and LH. And the major issue is you're going to distinguish it because of the anosmia. So in actuality, Kalman syndrome, and Americans don't like eponymous names named after people. But Kalman's is easy to identify because there's anosmia and low gonads. Now you tell that apart from Klinefelter's because Klinefelter's makes a high FSH and LH, but the tissue receptors don't work. Now it comes out to being the same thing, but Kalman's you have a low FSH and LH, no sex. Klinefelter's you have a high FSH and LH, no effect. It comes out to being the same thing, but Kalman's anosmia and Klinefelter's is tall and thin. Now, postmenopausal is the same as primary hypogonadism. Look at the numbers. Low sex steroids, high FSH and LH, high FSH and LH. So 1 and 4 are the same thing. Postmenopausal and primary hypogonadism are the same thing. Anabolic steroids. Remember, in anabolic steroids, what will happen is that you'll get a high sex hormone level and you'll get a low LH because testosterone inhibits the pituitary for LH. Remember, inhibins will make FSH go away. How come this FSH thing has gone away here? because after a while, without Leydig cells, the Sertoli cells are going to disappear. If you have testosterone, the testosterone shuts off the LH. Without the LH and the testosterone, the Sertoli cells involute. Now, inhibins are a great potential contraceptive because they only affect the Sertoli cells in the sperm, but they don't touch testosterone. That means your libido stays intact. You're just shooting. You're even going to have ejaculation. It's just going to have emptiness in it. Won't have anything in it. Now, this last thing about gonadotropin hormone, GnRH agonists, remember that all hormones are secreted in pulsatile fashion except thyroxine. So the reason that we use gonadotropin-releasing hormone agonists therapeutically is if you give them constantly, there'll be downregulation of the pituitary. But that has to be constant. Initially, it will bump it up. For example, let's take our final case. We have a 72-year-old guy who's got prostate cancer. This is a very important case. He's got prostate cancer, and he's got spinal mets, back pain, and metastasis to the spine. Prostate cancer, metastasis to the spine. Radiation therapy has begun. What is the next best step? What should you use first? Prostate cancer, you get it, hormonally dependent. Spine mets, emergency, gonna get paralyzed. You radiate them. And you use steroids, okay, we'll even throw that in. We'll even throw in the prednisone or the dexamethasone or whatever glucocorticoid you want. Prednisone, radiation. Okay. What hormonal therapy do you want to start first? Finasteride, flutamide, GnRH agonists. Spine mets, prostate. What hormone therapy first? The answer is flutamide. You must use flutamide. And this is another great final point for the section. Flutamide blocks the tissue testosterone receptor. If you start with a gonadotropin-releasing hormone agonist, also known as leuprolide or goserelin, if you start with a GnRH agonist, you're going to bump up the testosterone level. The spine met will expand and he'll be paralyzed. How do we take this physiology and use it clinically? How do we take a case and ask you a physiology question? A man with metastatic prostate cancer is brought to the hospital. He is started on hormonal therapy, and 2 days later, he is paralyzed from the waist down. Which of the following was most likely to be used? GnRH agonists. A man has metastatic prostate cancer. GnRH agonists are started first. He is paralyzed. What is the mechanism? What is the mechanism? And the answer is, when you give GnRH agonists, there's a bump up in LH, FSH, and testosterone, enough to expand the size of the lesion, paralyze the guy. You block the tissue receptor with flutamide. What's the other wrong answer? The other wrong answer is finasteride. Finasteride blocks dihydrotestosterone. Finasteride is a 5-alpha reductase inhibitor. Finasteride is good for benign prostatic hypertrophy and for baldness. And you could use finasteride, and he will have the best head of hair in the hospice. He'll have the best head of hair in the neurological paralyzed people's unit. So his hair will grow, but he'll be paralyzed. Finasteride will not work for metastatic prostate cancer. Finasteride is for BPH and for baldness. Flutamide blocks the tissue receptor. GnRH will block it, but not at first. Flutamide to block the tissue receptor, then GnRH agonists. Because remember, there's a bump up at first. How do we take this physiology and ask you questions? We give you the case and say, what's the mechanism? You say, well, why are you telling me about finasteride if it's not the right answer? Because it's going to be a choice. It's going to be a choice. Don't choose it. Right? Don't choose it. Finasteride will be there. It's easy to screw this up. 5-alpha reductase inhibitors do block dihydrotestosterone. The whole chapter says active form of testosterone, active form of testosterone. Easy to screw that up. But it doesn't make the prostate cancer grow. It makes the prostate for BPH grow, but not prostate cancer. Don't start GnRH agonists without flutamide first in people who have metastatic prostate cancer. The last thing is, what is the fastest way to lower testosterone levels? The fastest of all things. Orchiectomy. Orchiectomy is actually the fastest, but not necessary most of the time. But it was the fastest. If you give flutamide and GnRH agonists, it's an orchiectomy. It's called complete androgen blockade. But just remember, start with flutamide, block the exit, then the GnRH agonist. Finasteride for BPH and baldness, but not for prostate cancer. And what's the other thing is here? What antibiotic? What antibiotic will achieve the same effect? Ketoconazole. How do you ask that question? You say, which of the following drugs is most likely to benefit this patient? Fluconazole, ketoconazole, clotrimazole, amphotericin. I don't know. Do you understand the ketoconazole is anti-androgenic? A patient comes in with cryptococcal meningitis. He is placed on oral antifungal therapy for the last 6 weeks. He notices that he's developed erectile dysfunction. Which of the following is most likely to have been used? Ketoconazole. A man is placed on ketoconazole for metastatic prostate cancer. What is the mechanism of its effect? Anti-androgenic. Like an orchiectomy in a pill. Ketoconazole. Very good question. See you in the next section.